I'm Patrick Williams. I'm hosting this particular tech talk, and it's kind of serendipitous. I've been helping externally with an integration with Google Health. And Ray and Kevin were introduced to the project because of a Parkinson project that they're looking at, and they wanted to come here and share some information about how Google can help with telecommunication and telemedicine, and specifically around the Parkinson disease and some of the research that they're doing. So without further delay.
Good morning. My name is Ray Dorsey. Kevin Biglan and I are both neurologists at the University of Rochester and are very pleased to be here to share ideas with you. We thank Patrick Williams very much for the kind invitation to speak with you today. We want to talk to you about Parkinson's disease and how simple web-based technologies can improve care and the clinical research related to Parkinson's disease. And using Parkinson's disease is just an example of a chronic condition, and that how this model can be applied to other conditions as well. So this morning we'd like to talk to you first about Parkinson's disease as a chronic condition whose burden is growing both in the United States and globally. Second, how telemedicine using simple web-based video conferencing can extend the reach of care. Third, how telemedicine can also improve the conduct of research, and then discuss with you some next steps and future directions. So first, Parkinson's disease is a chronic condition that is readily treatable. It's defined clinically by observation by the presence of having two symptoms, an asymmetric rest tremor, slowness of movement, rigidity, or difficulty walking. We still don't know what the cause is as of 2010. About 10% of the cases we think are due to genetic mutations. The balance of the causes we think are due to environmental exposures, and the pathological hallmark is loss of nerve cells in the brain that produce a chemical called dopamine. The treatment is quite effective, especially early in the course of the disease, and was developed about 50 years ago, and it consists of replacing that dopamine that is lost in the brain. Surgery is another treatment that's been more recently developed and is an option for some individuals. Parkinson's disease, unlike other chronic conditions, often defines an individual. People have a tremor, they have difficulty walking, and so they're readily identified as abnormal or that something is wrong with them. And that affects them, it affects their caregivers, it affects their social interactions with everyone, and it's a difficult burden to bear for individuals. People bear this burden for a very long time. People live for, on average, about 14 years of their life, maybe a fifth of their life with Parkinson's disease, and 40% of these individuals will require nursing home care at some point in time. So this is what Parkinson's disease looks like.
All right, the masters start today.
This is just a video clip showing some of the hallmarks. One is you can see that his right hand has a little bit of tremor.
Keep your arms out there for me. Just go back and forth like this for me, fast as you can.
You can see there's some slowness in movement, especially with his right hand compared to his left. And again, the tremor.
Open and close your hands for me. Open and close.
You can see that his face has
Take your
much
right
less
hand,
expression
tap your
than
fingers for me,
normal.
wide and fast as you can. Just these two. There you go. And the left hand, wide and fast as you can. And put your arms across your shoulders and stand straight up for me. Perfect.
And you can see that when he walks, his right arm barely moves. He takes short strides. He's got a stoop posture, and he's got a tremor. So these are all the clinical hallmarks of Parkinson's disease. The challenge is that due to aging demographics, both in the United States and globally, the burden of Parkinson's disease is going to grow substantially. So between 2005 and 2030, doing some work that we did, countries that are going to experience 0 to 50% growth in the number of individuals with Parkinson's disease are some countries in Western Europe and Japan. The number of individuals who are with Parkinson's disease is going to grow between 50 to 100% by 2030, including the United States, Russia. The number of people with Parkinson's disease will increase by 80% in the United States. And there'll be more than a doubling of the number of individuals with Parkinson's disease in many of the developing economies of the world, including China and India. Looked at a different way, in 2005 we estimate that in the world's most populous countries, conservatively there's about 4 million individuals with Parkinson's disease. By 2030, this number will more than double to over 8 million individuals, and more than half of these individuals with Parkinson's disease in the world's most populous countries will be Chinese. So this is not a United States problem, this isn't a national problem, this is a global problem. The challenge is even greater because in the vast majority of these countries, individuals with Parkinson's disease have never sought treatment for their condition and have never received treatment. And this is despite the fact that Parkinson's disease is readily treatable with medications that decrease the risk of death, and that these medications are quite affordable and inexpensive. So what can we do? We know that improved access to specialists who care for Parkinson's disease or for any chronic condition improves care and outcomes. So that if you have increased access to specialists, you get higher quality of patient care, and that leads to improved outcomes and quality of life. This is true for heart disease, where you have more appropriate medication use and increased survival. For asthma, we have greater adherence to medical guidelines and improved quality of life. And for diabetes, where you have better process measures and fewer complications. The same holds true for Parkinson's disease. Research that we did among 350 individuals across the United States with Parkinson's disease found out that individuals who see a Parkinson's disease specialist are 3 times more likely to be satisfied with their care than individuals who see a general neurologist. And this increased satisfaction was across every domain of care of Parkinson's disease measured, including information received about Parkinson's disease, the time spent with the physician, the information about complementary therapies for Parkinson's disease. The challenge is that even in the United States, access to specialists is very limited. So this is where we live in Rochester, New York. Here's Syracuse. And this area is the Finger Lakes region. This is about 150 miles in diameter. And in this area, there are over 30 nursing homes, and there are only 6 neurologists and not a single Parkinson's disease specialist. So even in the United States, if you're in Gilroy or if you're in Riverside and you have Parkinson's disease, your ability to access care is greatly limited. So how can we extend the reach of care? And we think you can do this with just simple web-based video conferencing. So 3 years ago, a nursing home in New Hartford, New York, population 20,000, has 250 residents. Their administrator estimated that 20% of their residents had some form of Parkinson's disease, and said, we have no Parkinson's disease specialists, we have no neurologists who are seeing these patients, we're just seeing a general internist who's coming and seeing these patients. Can you in Rochester provide care to our residents in New Hartford? So we said yes. And what we used to do that was very simple technology. We used a laptop computer with a broadband connection, a webcam, a microphone, some software from Polycom, encrypted software for security purposes, and that was it. The total cost of the entire setup, beyond a laptop computer and broadband connection, was $200. And they had a very similar setup on their end.
I'll just add that it's a laptop that we're not currently using. This is an outdated laptop. It's being thrown by the garbage. So it really costs for $200.
So this is in contrast to other telemedicine applications, which are extremely costly, capital intensive. This is not. So this is the first individual that Dr. Kevin Biglan saw about 3 years ago. He's an individual who's actually used to get his care in Rochester, New York, but since going to the nursing home was no longer able to access care. And we were called by the nursing home because this individual was having behavioral disturbances, was trying to climb out of the window of the nursing home, and was having trouble thinking. His score on our standard cognitive measure was 21 out of 30. He was on a medication for tremors that makes thinking worse, and he was on a drug called Aricept, which is used to improve cognition. So he was on a medicine to worsen his cognition and on medicine to help his cognition. Kevin saw him, and after a series of about 2 or 3 visits, changed his medications. His behavioral disturbances went away. He took off both the medications for one worsening cognition, one helping cognition. His score on the cognitive exam went to 30 out of 30. His behavioral problems resolved, and he became one of the most popular residents in the nursing home. So based on this pilot experience, we're researchers. We said, let's conduct a randomized controlled clinical trial to see whether improving access via simple web-based video conferencing can make a difference in the lives of people with Parkinson's disease. So we took 4 residents who have Parkinson's disease in this nursing home and assigned them to receive 3 visits with us via, again, simple web-based video conferencing over 6 months. And then we take 10 individuals who reside in the community. These are individuals who, go to the grocery store, live independently, they have Parkinson's disease, and we randomized them. Half were randomized to receive usual care for 6 months, whatever care they had been receiving, and half were randomized to receive visits with us via telemedicine for 6 months. Primary outcome that we looked at was feasibility, and we found that 29 of the 30 telemedicine visits were completed as scheduled. The one that wasn't was delayed for 2 weeks because the patient was sick. We found that our assessments that we do, the standard exam that we do for Parkinson's disease, was valid and reliable when conducted over a web-based video conferencing compared to in-person, so that the quality of the examination, with 2 minor exceptions, was just as good done remotely as in person. And we looked at other secondary outcome measures. So what does a telemedicine visit look like? I'm going to show you first a clip of an individual who resides in the nursing home at the beginning of the study, and then we saw him 3 more times, and we'll show you what he looked like at the end of the study, and you can see if you can see any differences. Good. The other hand. So this is me in Rochester, New York, and this is him in Hartford, New York. I'm just in the little conference room. He's in the conference room there. And then your left hand. And your left hand. And then the left foot. So he can't get out of a wheelchair. Good. That's not too bad. Good. Good. This is 6 months later, after we've adjusted his medicines. Do the right hand again, please.
Right hand.
Pretty good. How about the left side? Good. And the left hand? Good. And the left foot? So you can see his slowness of movement has improved. Good. Pretty good.
Here we go.
Okay. Okay, that's enough.
Yeah. I got it. Okay.
All right. Good. That's it.
Yeah.
So hopefully you can recognize at the beginning he couldn't get out of the wheelchair by himself. He couldn't walk. Ended the visit just 3 months later, 6 months later, after 3 visits, he can get out of the wheelchair. He can take a few steps by himself. You know, he can go to the bathroom, for example, by himself. He's clearly not normal, but clearly improved just over 6 months. So what does the data show? Well, the data showed that increasing access to specialty care improved quality of life and patient satisfaction. So this is a scale called the Parkinson's Disease Questionnaire 39. It's a standard scale for measuring quality of life of individuals. It's just a survey instrument that's used in a wide range of clinical trials for Parkinson's disease. Those individuals who received telemedicine had an improvement in their quality of life. Those who received their usual care had significant worsening. Then we measured patient satisfaction. Those who received telemedicine had significant improvement in patient satisfaction compared to those who did usual care. Of note, this difference in quality of life, if a drug did this, it would be considered the second most powerful drug used for Parkinson's disease, and this is greater change in quality of life than even seen for surgery. Granted, this is a very small study. And then that motor function, individuals with Parkinson's disease saw no progression of their disease over the 6 months, whereas those who had usual care had significant worsening of their disease over 6 months. So we were impressed, we were satisfied, but what really got us was the feedback we received from patients. And this is one individual who we said we're going to do the 6-month study, and at the end of the 6 months we weren't sure what was going to happen because we didn't know if we were going to continue to receive funding to continue the study. Do you have any questions?
After November 7th, then this program is done, and I am no longer connected to you.
Well, would you like to stay connected?
Yes, I would very much.
Well, the Presbyterian Home has been very generous in working with us to continue this for another year at least.
Okay.
Is that good?
Wonderful.
You've brought her to years.
It's made such a difference.
Can you tell me a little bit what's made it valuable for you?
I truly feel personally that I got the type of attention that I needed, but was not accessible to me because of the area where I live, because of my Parkinson's condition.
So she succinctly summarizes the value proposition that we're providing. We're able to provide care to individuals with Parkinson's disease anywhere that they live. So no longer is a person's access to care determined by where they live, but now that they can be free to live where they'd like to live and still receive the care that they need. Lest you think it's anything that I had to do with it, this is a patient of Dr. Biglan's and the feedback that she gave him. These are both individuals who reside in the community with Parkinson's disease.
Okay, now, I'm getting very disappointed that this is our last time I will see you probably. I don't know if they will extend you've been such a difference in my life. I mean, I've already lived 100,000 extra years. This is done. It's phenomenal.
And now, I think we got to figure out the particulars about it, but I think our plan is to continue doing telemedicine for another year. So,
So sort of hold that thought and see what happens?
yeah.
We are? Oh, this is a gift. Oh, my God. God is good. This world is great. It's great not to visit a place like this. I can't believe this. Oh, wow.
So most of our patients don't do that to us. So based on that feedback, we've been doing this now for 3 years with these individuals. They all continue to do exceptionally well, and we're looking to expand the model. So this is, again, Rochester, New York, Toronto. And this area, we live here in Rochester, New York. We're the Parkinson's specialists. In this area, there are 57 nursing homes, five neurologists, and no Parkinson's disease specialists outside of Rochester. So if you have, a Parkinson's disease or Alzheimer's disease or any chronic condition, your care is just from a generalist, whoever comes into the nursing home. And we say, well, we can do better. Can we provide care to the individuals in these different nursing homes who have Parkinson's disease? And that's what we're planning to do later this month, actually, is start a larger scale trial, just like we did with the first nursing home, but with 50 patients in 5 different nursing homes. This is, we're Parkinson's disease specialists, but this same model can be applied to virtually any chronic condition. So here in 2010, there are 140 million Americans who have at least one chronic condition. By 2030, this will increase to half the U.S. population will have at least one chronic condition. 80% of these individuals live at home, and these individuals account for 75% of healthcare expenditures in the United States. So how can we provide care to these individuals regardless of where they live? It's one thing if you live, in Mountain View, you can go to Stanford. Even that can be difficult for individuals who have limited mobility. But is there a way we can provide patient-centered care to individuals regardless of their location? And what we want to do next is to provide the same model that we're providing into nursing homes, but provide that care directly into individuals' homes. So providing a virtual house call. And this virtual house call can be done with widely available, just simple web-based video conferencing. I mean, most people in here probably use Skype. So you could practically use just Skype with some encryption to provide a care to households that have computers and broadband access. But the real value can be greatly enhanced through applications of Google. So you could merge the virtual house call and use Google voice and video chat and incorporate that with a Google Health record. You could videotape the encounters that you have with patients and store that as part of their electronic health record. That information can then be used to monitor their disease progression for the physician to see if the individual is doing well or responding well to medications, to educate the patient about how their disease has been changing, and for the patient to give you information that you wouldn't otherwise be able to capture. You can use Google to create virtual disease-specific communities, virtual support groups to educate or to provide support to individuals with Parkinson's disease. It's a relatively common neurological disease, but the vast majority of individuals feel isolated because they don't have friends or colleagues or peers who have the same condition that they have, who are going through the same thing. And the same could be true said of the caregivers. And Google's obviously making some efforts into increasing broadband access, and this could be another way to expand virtual house calls. Another way virtual house calls could be conducted via a simple plug-in computer, which you just plug in to the walls the size of your fist that Marvell is developing. And you can link the TV and camera to reach additional households that don't have computers, for example. And again, apply the same Google applications to enhance the experience beyond what is currently available. A television. Right now, televisions are used to distribute entertainment. But health and medicine could actually be a much more valuable application for a television than entertainment. And that Google TV could be used to provide it. Finally, you could provide truly mobile medical care through applications from web-enabled phones. And the Nexus One phone, it's just looking with Patrick today, is more powerful than a stethoscope and can be a very powerful medical tool for increasing access to care. We think that the model with telemedicine can actually be better than current model of care. So most of the time, telemedicine is viewed as some substitute for care for individuals who otherwise can't access it. But there are many ways in which telemedicine can be much greater than, or much better than the current model of care. So the current model of care is that you drive to Stanford to see your neurologist who have Parkinson's disease, and you have a doctor-to-patient relationship. And that's a very nice relationship. If you do virtual house calls, you can still have that patient-to-doctor relationship. You can actually have a relationship between the patient, the caregiver, and the doctor. The classic story is mom has Parkinson's disease, she lives in Mountain View, and she goes to see her doctor, but her daughter, who's increasingly becoming involved in her care, lives in Iowa. The current model is that the person has to travel from Iowa to Mountain View to go see her patient, to go see her mother, to go see the physician. Now you can have these people be in different geographic locations and receive care. Many patients with Parkinson's disease can see one doctor. Doctor could do a group educational session. Or many doctors could see one patient. If you have Parkinson's disease and you're having depression, you could see a neurologist and a psychiatrist, for example. The current model of care is synchronous. The patient and the doctor must meet at exactly the same point for care to be provided. With virtual house calls, you could have synchronous visits, or you could have asynchronous visits, in which patients can provide data. Doctor, sometimes my arms moves like this. Could videotape it, video clip it, and send it to the physician for the physician to interpret at his or her convenience. Similarly, the physician could provide information to the patient that the patient could access or take part in at his or her convenience. Currently, the physician, the patient must be in the same place at the same time. Right now, you can free both the patient and the doctor. Kevin and I are taking a red eye back to Rochester, New York tonight, principally because we both have patients tomorrow to see in clinic. If we could do web-based video conferencing, we wouldn't have to take the red eye. 3 months ago, I was scheduled to see patients via telemedicine in our office in Rochester, and I was home with my sick child. And I was able to do everything from home, except I actually had to find a babysitter, watch my kid for 2 hours so I could drive to work to go see the patients via my web-based video conferencing set up at work. If I had it at home, I wouldn't have had to go into work. I wouldn't have had to find a babysitter for my son. Just could have done it from home. Costs. There's substantial travel costs. If you think about the time that you spend when you go to the physician to see a physician for 15, 20, or 30 minutes, you should probably spend 4 times that amount of time at least just to go see the physician. Many of our patients travel over 100 miles to come see us. They spend more on transportation. They spend more on just transportation, gas, car, and tolls than they do on the visit themselves. Medicare pays us $70 for see a patient and follow-up. If someone's driving 100 miles round trip, 100 miles each way, that's IRS would pay you $100. They pay more for travel than they do for the actual visit. There's an enormous loss of labor productivity from both the patient who is maybe working or often from the caregiver. These are extremely resource-intense environments. Hospitals and physician clinics are very expensive places to receive care. Virtual house calls, no travel costs, minimal loss of productivity, low capital investment, $200, probably less, minimal overhead. Delivering care to people's homes is not a pipe dream, it's feasible. Right now, the number of individuals, households with high-speed internet access is at least 75 million. Just last week, the Federal Communications Commission released its strategy to bring high-speed internet access to 7 million U.S. homes that lack it, while making existing broadband connections that serve 100 million households at least 10 times as fast. I'm now going to turn over how telemedicine can not only improve care, but improve conductive research to Dr. Kevin Biglan.
Good morning. Thanks again for inviting us. We really welcome the opportunity to talk to you all about the work we've been doing in Parkinson's disease and using remote technologies for both for clinical care and for the conduct of clinical research. And so I'm going to focus now on our vision for using remote technologies in clinical trials and other clinical research endeavors. So developing drugs is an extraordinarily expensive proposition, and this proposition has increased dramatically over time. And so the average cost for bringing a drug from preclinical trials to clinical development and FDA approval is about $802 million. Half of that cost arises from the time required to conduct the research. The majority of that time is devoted to recruiting subjects and recruiting appropriate individuals to participate in the clinical research, the clinical trials of specific drugs. In addition, we have to enroll about 20% more people in clinical trials than we think we need to answer the scientific question at hand, largely because we anticipate that about 20% of individuals will drop out of studies. And so there's a large inefficiency there in that. If we can somehow enhance the time for recruiting individuals, maintaining individuals in studies, then certainly we could reduce these costs dramatically. And to give you an idea, about 5% of all healthcare expenditures, or $60 billion, is spent on clinical research for new drugs. So we are very passionate about the idea that we think that remote assessments can really be valuable in this context. We think it would be dramatically reduce costs. One of the other driving forces of cost for clinical trials is that that individuals who are in studies have to be seen relatively frequently, sometimes as often as every 4 weeks, sometimes more frequently than that, in order to really assess the safety of the study and to do clinical assessments on those individuals. Remote assessments would allow us to really only do those in-person assessments that are critical for the safety and conduct of the trial. Most of the other assessments could potentially be done remotely. And that would be a huge cost savings because in terms of so we have to, in order to conduct this research, we have to pay those investigators who are doing the in-person assessments a certain amount of money. We often have to pay for travel for individual subjects enrolled in studies, and you can imagine the cost there. The bigger issue, as I alluded to previously, is that we would save time on recruiting individuals and subjects into studies. We often account 6 months, year, sometimes 2 years to enroll all the individuals in the study. A lot of people's reluctance to be involved in clinical research has to do with the time commitment. And so the extent that we can say that, look, we only need you to come in twice, all the other visits can be done remotely in your home, we think we would enhance recruitment that way. Maybe a little bit more technical is the issue of currently most studies, particularly in diseases like Parkinson's disease, where you really need to recruit large numbers of subjects to be able to answer the questions that you want to answer, we have to have multiple centers, both nationally, often internationally, to enroll that number of subjects into our trials. So you have a number of different individuals, different locations throughout America, throughout the world, who are evaluating these individuals. And there's a lot of variability that's merely associated with that investigator evaluating that subject. And you have to account for that variability in terms of your ability to detect meaningful treatment effects. So if you could use a single individual to rate all these subjects on your most important clinical measures that are going to be most useful for evaluating whether the treatment works or not, we think you'd reduce the variability considerably. We know we'd reduce the variability considerably, and that would reduce the number of participants you need to enroll in the trial and therefore reduce costs. Recruitment, I'm going to harp on this a lot. Clinical trials for participants is burdensome. There's the travel burden. You're really limited to individuals who are geographically close to the site in question that's conducting the research. Individuals with Parkinson's disease have marked mobility issues, as you saw, and so they really need we need to facilitate that as much as possible. To the extent that we can reduce the burden on individual participants, we think we can enhance recruitment and also, more importantly, potentially allow these individuals to stay and study, and then maybe we wouldn't have to recruit that additional 20% of individuals above and beyond what we need to answer our scientific questions. I think I touched on this already, is the geographic scope. You have to be geographically close to currently to a site that's conducting the research to do it. That really excludes individuals who are, living very rural environments. We have a colleague who now lives who works in the University of Utah in Salt Lake City. His catchment area in terms of the individuals that he sees is probably 5 different states, all in the Rocky Mountain area. We know travel through that area is very challenging. Most of these individuals are lucky if they can see a Parkinson's disease specialist once a year, if at all. And certainly they're not going to be able to participate in clinical research trials where individuals have to come in on a frequent basis to be evaluated. More importantly, potentially, is the ability to expand the population pool to individuals who otherwise would not participate in research at all. And so these are individuals with who are mobile, but also individuals living in nursing homes. A lot of the unmet therapeutic needs, particularly in Parkinson's disease, relate to conditions like dementia, cognitive impairment, and psychosis, hallucinations. The majority of those individuals with those problems actually reside in nursing homes and are not participating in clinical research and clinical trials, so our ability to develop drugs that address those really unmet therapeutic needs is limited. And we think, and we've shown that certainly you can evaluate people in nursing homes with this technology, and that you can get, and that it is almost as good, or if not as good, as in-person assessments. And so you could really open up therapeutic research trials to a whole cohort of individuals who would otherwise not be able to participate. Finally, we think remote assessments may potentially be an improvement on our current model. Similar to our clinical care, where we think that evaluating people in their homes is more maybe better than actually the in-person assessments that we currently conduct. If you think about it, we currently conduct an in-person assessment. It's a snapshot in time of that individual. They're in an unusual environment. They've maybe traveled an hour to get there, which has an impact on how they're functioning or how their symptoms are. And then we have to get a subjective sense for how they're doing at that time point based on how they think they're doing, which is often more a reflection of how they're doing right at that time and not a good reflection of how they're doing over time. So as Ray stated, the ability to have asynchronous evaluations where you record clinical information at different time points when they're occurring and then evaluate them at a later time point may be more meaningful in the sense that you're seeing people in their home environments, you're seeing them at times that you would not otherwise be able to see them. Similarly, we can do the same thing in clinical research. One of the important aspects of conducting therapeutic research in Parkinson's disease and other chronic conditions is the ability to monitor safety very closely. Currently, we put the burden on the participants to let us know if they have any safety concerns or side effects that are potentially related to the experimental treatment in question. And that's a big burden to put on an individual, particularly with a chronic condition. Oftentimes, we don't find out about these things until months later when they come see us as part of their research visit. And so the ability to really detect these safety concerns in the individual's home in real time with as little participant burden as possible is a very valuable proposition for clinical trials. In Parkinson's disease, we often ask individuals to keep written logs of how they're functioning in order to address the idea of, in order to address whether or not treatments are having any impact on a day-to-day basis on their function. It's very common for individuals to be sitting in the waiting room on the day of their visit, filling out their written logs that should have been done throughout the time period. And so these, it's amazing actually that we've seen treatment effects on these subjective diaries that actually have led to FDA-approved medications for Parkinson's disease. But certainly the implication there is that the treatment effects may actually be greater than what we're seeing. And the ability to, with little participant burden, evaluate some of these clinical outcomes in real time is very valuable. Finally, the ability to take that data as soon as it occurs and upload it directly into our analytic database allows us to monitor safety on an ongoing basis very easily, and we think the quality of data, therefore, would be better. again, about recruitment, there's been a lot of work on trying to understand what are burdens to participation. In general, in Parkinson's disease, less than 5% of individuals with Parkinson's disease participate in clinical research. Similarly true in other chronic neurodegenerative conditions. Most people do not participate in clinical research. And the question obviously is, what are the burdens on individuals that prevent them from participating? And so Korowish did a study, a survey study largely, where he asked individuals with Alzheimer's disease, what are the things that prevent you from participating in research? And the number one thing that was most important was the travel burden associated with frequent visits. And they found that if you really did home visits for individuals, that you could enhance recruitment dramatically. The other things were associated with risk associated with the drug and the chance of receiving placebo. But above and beyond that, home visits, travel burden was the most important. And so for very little cost, they could enhance recruitment into trials, but just by participating in home visits. And we think, why go out to the individual's home when you can assess them remotely in their home, potentially for a much lower cost? So now I want to talk about a collaboration. Talk about a study that I'm involved with that's funded by the Michael J. Fox Foundation, and specifically about a collaboration with Marvell and their plug-in computer in order to enhance our ability to detect important safety outcomes in this trial. So isradipine is an antihypertensive drug. That means it lowers blood pressure. That's its main goal. It's what we call a calcium channel blocker type of drug. And it's shown a promise in Parkinson's disease. So it's shown promise in Parkinson's disease animal models that it may prevent or prevent Parkinson's disease in those models. And then more importantly, actually, in a number of large epidemiologic studies in individuals who are otherwise healthy. They looked at individuals over time in these primarily European healthcare databases, where they really have almost complete capture of all individuals within a community. And they looked at and said, well, if you're taking certain types of medications, what was your risk for Parkinson's disease 10 years down the line? And they found that calcium channel blockers, and specifically the type of calcium channel blockers that isradipine represents, really lowered your risk for developing Parkinson's disease. And other blood pressure medications had no such effect. So there's a lot of good evidence, from previous data that suggests that isradipine may be a useful study to drug in Parkinson's disease, that it may prevent or slow the progression of disease. So I talked about isradipine lowers blood pressure, so it actually has the potential for having significant serious side effects. In addition, individuals with Parkinson's disease are at a very high risk for low blood pressure. In general, they tend to be hypotensive, they tend to have low blood pressure. They tend to have difficulty regulating their blood pressure. And so one of the major concerns in giving people with Parkinson's disease who are prone to low blood pressure to begin with and often have baseline low blood pressure is, can we worsen that and cause serious complications? So our study is a phase 2. It's a safety and tolerability study trying to identify a dosage of isradipine that is both tolerated and shows preliminary evidence of efficacy in individuals with Parkinson's disease. It's a 1-year study. And we thought that, the current model is that individuals, as they slowly increase the dose of the drug, are required to take their blood pressure twice a day. The blood pressure, actually I'm going to move on to the next slide. The blood pressure monitor, wrong one. What's that? I got it. The blood pressure monitor here is a digital monitor. It has some memory capabilities. It's able to store the blood pressure recordings. And so it does store those blood pressure recordings. In addition, those blood pressure monitors are brought in about every 2 weeks or so to the research site. It's uploaded to the database about every 2 weeks. In addition, we need to know at the time of the in-person research visit whether a person is tolerating the drug so that we can increase to the next dosage, to the higher dosage. And so the way that we've approached that is a very inefficient way. We've asked individuals to actually keep a written log of their blood pressure recordings. So you think about it. We're asking them to take their blood pressure twice a day. We're then asking them to also, in addition to taking it, keep a written log of that blood pressure recording. And then every 2 weeks they bring that information in. And so we're really missing valuable time in terms of addressing any potential complications of drug. We're putting, again, the burden on participants to record their blood pressure and also to notify us if they think there's a problem associated with their blood pressure recordings. And so this is actually a relatively significant burden for these individuals with Parkinson's disease, with reduced mobility, with reduced ability to write. Writing is often impaired in Parkinson's disease. And so our solution was to utilize the Marvell plug-in computer to upload the data on a regular basis, ideally on a daily basis, so that as investigators, we can look at the database and look at it in real time and make determinations about the safety of the drug in real time. And we've also we've reduced participant burden because individuals no longer need to record a written log. That data is available to investigators. They can go on to, currently we're uploading it to Google Health. They can go on to Google Health, pull up that individual's health record with permission from the individual, of course, and evaluate what their blood pressure has been doing at the time and make a determination about whether it's okay to increase their medication. Still at this point, it requires that individuals take their plug-in computer and plug it into their wireless router or what have you, so that the information is uploaded to the internet. But certainly the technology exists to make this a completely remote process so that individuals would take their blood pressure and be done. They plug in the plug-in computer into the wall, they take their blood pressure, the data is automatically transferred to Google Health or similar repository, and you could imagine that you could set settings on it so that an investigator might get a text message or what have you that if the blood pressure is out of range or too low, so they can act on that immediately. So we think this model really suggests that remote assessments may reduce burden on participants, improve safety outcomes for individuals participating in clinical trials, and ideally save money. In addition, we see the idea of doing assessments in the home as a means for evaluating how people look clinically, what their examination shows, maybe other assessments of how they're functioning, and genetic studies. So 23andMe, as many of you are probably aware, is an initiative to evaluate genome or genetic data on individuals. And individuals basically sign up. I think they pay about $400, and they get a number of they get ancestral information, which I think is a lot of the driving force for a lot of individuals. But they also get specific gene-specific data that's related to disease risk. And so they'll learn about their genetic risk for a variety of diseases, including Parkinson's disease, as well as male pattern baldness, but a variety of other things. We think that that's interesting cohort to look at. In addition, through 23andMe, they've developed a Parkinson's disease initiative. They're specifically interested in looking at individuals with Parkinson's disease. So they've made it very cost minimal for individuals with Parkinson's disease to get their genetic data. So I think they request $25 if you have Parkinson's disease. The question becomes, you're asking a community of individuals without medical, whether or not they have Parkinson's disease or not. Many of these individuals probably have not been seen by a Parkinson's disease specialist or maybe not even by a neurologist. And you're getting information about their genetics and you're assuming that they have Parkinson's disease or some related condition. And the reality is the data quality is quite low because you don't really know what they have. We can see that remote assessment is via web-based video conferencing, potentially using the plug as a mediator for evaluating the video data, would be a useful, easy way to, one, identify what their clinical examination shows in a very rigorous manner, determine whether or not they have Parkinson's disease or some other related Parkinson's-like disorder or some other related neurologic condition. It's very common for individuals with tremors to be diagnosed with Parkinson's disease and not have it. And in addition, it allows you to follow clinically over time what happens to these individuals very easily and in a cost-effective manner. So we get genetic data. It'd be interesting to know that if specific genetic genes associated with Parkinson's disease, or maybe even genes associated with other conditions unrelated to Parkinson's disease, have an influence on how people behave over time in terms of their physical examination and maybe other features. In addition, the cohort of individuals who are otherwise healthy and sign up for this service, a proportion of them are going to actually have genes that put them at risk for Parkinson's disease. So these are individuals who are at risk, unbeknownst to them oftentimes, at risk for Parkinson's disease based on their genetic profile. And it gives us an opportunity to evaluate those individuals who are not yet sick, follow them, again, in a very cost-effective, low-burden type of way, and determine what are the features that first unfold, what are the features of disease that are most important in this pre-symptomatic period prior to the onset of symptoms and prior to diagnosis, and allows us to potentially develop therapies that would delay the onset or prevent disease onset in these populations. So I think that these genetic studies and coupled with remote assessments is a very powerful means for evaluating a variety of questions in Parkinson's disease and potentially developing therapies that may prevent or delay the onset of disease. I'm just going to click, okay. So finally, I want to say that another issue is using remote technologies to get a better understanding of really day-to-day function and day-to-day disease manifestations. So we've talked about the fact that people with Parkinson's disease may have some variability in their function throughout the day. They may have involuntary movements. It's often very difficult to know what people mean when they have these types of problems without actually visualizing it. And there may be automated technologies using devices like the Google phone or other simple devices that include accelerometry, so you can detect movement, position, you can potentially identify mobility, how often are people active during the day. We know that exercise and activity is very important for improving function and delaying progression in Parkinson's disease. Falls are an important morbidity in Parkinson's disease. Falls are associated with fractures, nursing home placement, and death in Parkinson's population. So monitoring falls and people are very poor at reporting how often they fall or when they fall. So the ability to automatically detect falls in this cohort would be very useful, both from a research perspective, but you could imagine from a care perspective, if you can get notified or somebody can get notified whenever an individual with Parkinson's disease falls. It's the, I think as Ray mentioned, it's the 21st century, help me, I've fallen and I can't get up. Medication response, daytime activity. People with Parkinson's, and particularly people with Parkinsonian disorders, are prone to sleep apnea. And using infrared technology, we could potentially monitor carbon dioxide levels in individuals and develop interventions to address elevations in carbon dioxide associated with sleep apnea. And importantly, using UV detectors that can be available on these phones and other devices, we can monitor sunlight exposure. Recent data suggests that sunlight exposure is associated with conversion to vitamin D. Vitamin D appears to be important for preventing cognitive impairment and dementia. And so there's reasons to think that it'd be important to monitor. You guys don't have this problem in Northern California, but in Rochester, New York, everyone has vitamin D deficiency. So we just want to finish up talking about what we see as next steps and future directions for our research and where we think the collaborations may exist. So we think that we can use Google applications, capabilities, and resources to expand the telemedicine model, primarily for care. As Ray talked about, virtual house calls. We are all aware of Google Chat and Google Video as an alternative means for performing virtual visits in individuals' homes. Our understanding that can be encrypted in a manner that can be utilized. Utilizing the plug-in computer to allow people to, with a camera and a TV, to perform virtual house calls in that manner. For research purposes, both using video conferencing and things like monitoring blood pressure, monitoring mobility, monitoring medication response in real time. And we'd like to assess the feasibility and value of new technologies and services, such as the Marvell Plug computer. I think I've already talked about this, Google Health, for delivering care and performing research. And ultimately, we'd like to expand the geographic scope. Most of our research has been conducted in the Western New York and upstate New York region. We'd certainly like to expand it to other states, and from a research perspective, we'd like to expand it to multi-center trials. The study I told you about is a multi-center study, but the research we're doing is really done at the University of Rochester at this point. We have visions of expanding that to multi-center trials and showing that we can conduct the same assessments that are conducted in person remotely just as well, and that would really have a huge impact on drug development and drug development costs and participant recruitment and retention. Ray is taking a faculty position at Johns Hopkins, and that really opens up an opportunity for us to explore this technology in Maryland and probably internationally. So this is our vision for the expansion and timeline for our expansion. So first, we plan on providing care to individuals directly in their homes, and that's something we plan on doing actually probably next week. So we want to test the feasibility of performing virtual house calls and ultimately expanding it to see whether or not virtual house calls are an improvement over traditional care, both in terms of costs and the quality of information that we receive. Next, we'd like to expand, incorporate remote assessments into research studies. We talked about 23andMe as we see as being a very meaningful use of this type of technology and into existing and future clinical trials. And finally, we'd like to apply the model to other chronic conditions, for example, Alzheimer's disease, which is a chronic condition associated with aging, which is increasing in prevalence dramatically as the population ages, and expand the geographic scope both within North America and also internationally. And ultimately, as the one patient that Ray showed you so eloquently put, our vision really is to provide patient-centered care to individuals with Parkinson's disease no matter where they live. And we want to thank you for your time, and we're happy to take any questions at this point. Scott.
I had one based on the discussion we had earlier. The care that you gave to the nursing homes was largely dependent on someone at the nursing home setting up the conferencing, right?
Yes.
So there's still a difficulty of configuration for these people getting even remote care. You say that's true?
Well, we don't know. Oh, so the question was that in our nursing home experience, and in fact in our community experience to date, we've modeled it around having these telehealth centers. So we have a telehealth center that is local to the individuals that are participating in it, but is so it's convenient for them, but they still have to leave their home to come to this center. It's in the nursing home, so the nursing home individuals actually are right there, and that's actually been a tremendous convenience for them. But we've had individuals there that have done two things. One, they work the camera on their end, so if we ask to see something specifically, they move the camera to that specific location. In addition, we have a nurse that we've trained to do some Parkinson's disease evaluations. And so the question is, when you move this type of technology or this type of service into the home, you really, somebody, I forget the term somebody used for this once, but it's, unassisted telemedicine visits. There's nobody there necessarily. There may be a caregiver, but there's nobody there with training or expertise to perform these. And so we're certainly interested in assessing whether that is actually a feasible possibility. We think it is feasible. We think we can get enough information in order to make marked improvements in the quality of care and in patients' function and quality of life. Did you want to comment on?
The technology is exactly the same technology Grandma's using to speak to her grandson. So why can't Grandma speak to her doctor?
All really great, very exciting. What have been some of the challenges you've come across in terms of people adopting this method? I know the sort of lack of in-person, there's a certain impersonal feeling about having a computer separating two people. So have there been any sort of drawbacks you've seen on that end?
So the question is, what are the, the barriers to people adopting this model on a larger scale? And one of the things you raise is whether there's you don't form that traditional physician-patient relationship, and there's a little bit impersonal through the computer. And so we did conduct focus groups to try to address that very specific question in the people that have participated in the studies thus far. And we've actually found that not to be a concern of theirs at all. In fact, in general, the relationship that people feel that their relationship with us via telemedicine is better than with other doctors they've seen for their Parkinson's disease. There's been no concerns at all about the interpersonal issue. I would say, and I'm going to segue to Ray on this, the major barrier to adoption has largely been in terms of reimbursement for telemedicine services, and I'm going to let Ray speak to that issue.
Sure. So although you physically don't touch the patient, you touch them in a different way. And I think you actually touch them in a more meaningful way. The current way that we deliver care is really centered around the doctor's convenience. You come into a waiting room, a holding cell, you wait until the doctor's ready to come see you, and he comes out and sees you. This way, we're actually coming to you. We're coming directly into your homes to provide care to you in the most meaningful way possible, in the most patient-centered way that we know of in 2010. Reimbursement is a challenge. Medicare currently covers telemedicine visits in certain settings. It doesn't cover it in non-rural areas, such as Hartford, New York, population 20,000 for whatever reason. We think it's just a matter of time before payers will change. I think there's other alternative economic models by which that this can work as well.
To your experience as a developer, what was the first initiative to pick up the Plug computer, and who, developed the tool itself? Was it you? Was it easy for you? I wanted to have this kind of.
So how did this program get initiated, and what were the
With you.
with it with
Specifically as the plug?
Yes.
the Plug? You do.
Well, actually, Marvell came to us. We were involved in, they were interested in whether or not this could be a useful technology in clinical trials, and they said, who's doing clinical trial work? And you got Carl Kiebert's name, and ultimately he referred you to us because we were doing some of this remote assessment work already. And so we met with Scott Smith and said, yeah, we think this is valuable. We're doing a clinical trial in Parkinson's disease where we need to monitor blood pressure. This seems like this would be a very useful test case and a simple way of improving the way that we're currently doing things, both in terms of efficiency and reducing participant burden and improving safety. With that in mind, I think Scott configured the device to make it compatible with the blood pressure monitorings that we were already using in that study. And so we didn't do any of the technology aspects ourselves in that regard.
If we go this direction, will be feasible for doctors and physicians like you to develop, take this tool and develop, or you will need any support from us?
I would say that we would probably need support in terms of the technological adaptation. So say, one of our goals is to be able to increase access to web-based video or video conferencing technologies so that we can do visual evaluations of individuals. I think it's, in the short term at least, it's going to be we're not going to be able to get around doing some type of visual synchronous evaluation, particularly in the context of clinical trial work. There are just regulatory issues around that. And in terms of FDA approval processes, there are certain outcomes that need to be assessed in order for a drug to come to development. So we think the Plug computer potentially is a means for improving access beyond those individuals with computers and beyond those individuals with broadband access, potentially using other, the 3G network, satellite, et cetera.
I just have a question about kind of the overall penetration of telemedicine. I'm interested to know, I think it's great that you guys are using it like this. Obviously, we have other technologies that could support the evolution of telemedicine, and this is the first real time I've heard of it being used. So is it rare? Is it something that's growing?
So the question is the overall penetration of telemedicine. Do you want to talk?
So telemedicine is being done every day. It's being done right now. It's been widely used in psychiatry and other fields for many years, many decades. So, for example, telemedicine is used to provide care to individuals who in prisoners, where it's very difficult to get it. It's used in the VA system to provide care to veterans, wherever it is. It's used to manage acute emergencies, so stroke. You can get physician-to-physician consultations. It's used in radiology, where you can now separate the acquisition of a picture or an image from its interpretation. It's used in dermatology. It's used in a wide variety of ways. You can get a second opinion from a doctor right now if you wanted to on a runny nose. I think what we're trying to do is change the model a little bit and that apply it to chronic conditions, such as you can develop a longitudinal relationship with patients over time and free that individual and even free the physician from any geographic restrictions where that individual lives. There's no reason that in 2010 an individual has to decide where they want to retire based on their medical conditions and their proximity to physicians. And there's no reason that an individual, in Bangkok can't get treatment for his Parkinson's disease because there aren't Parkinson's disease specialists in Bangkok. Those types of things just no longer need to happen in 2010, and the technologies are already there. You guys can easily create the technologies to enable this. What's needed is, partnerships, creativity, and will. And we need partners, we need creative people, and we have some will that we'd be happy to pass on.
Would you say, though, that obviously the advances in technology make it much easier? I don't think 10 years ago you could have had that type of analysis, right, looking at someone through video.
I think the big thing is, it's cost. This is no longer a cost issue. You have mobile telemedicine vans, you have mobile telemedicine units, you have cameras at $5,000, $10,000, $100,000. There's robots out there that can make rounds for you for $300,000. Our solution is not capital intensive at all. It's low cost. It's $200. It's less than a couple months of a cell phone bill. It's readily available technology, but what's really needed is partnerships, creativity, and will to make it happen.
With this telemed, it sounds like, are you saying that your availability as a doctor as well has increased or are able to do research, you're able to sort of get more bang for your buck in terms of your time? So perhaps this means more patients get treatment? Is that sort of the correct thing to assume?
So does the productivity of physicians increase with telemedicine? And patients like time with doctors, and that's always going to be a scarce thing. And you can't make it right now that the time is relatively similar. We spend about a half an hour with follow-up visits. If you come see us in clinic, we spend about half an hour on time. Our no-show rate is much less for telemedicine visits than it is for regular visits. Our ability to conduct visits will be increased because we can now do it from our home, from our desk. Right now for clinic, we literally, both Kevin and I, have to drive from our office to go to clinic to go see our patients. When we see telemedicine, we don't move. We just turn on our computer and do it. With telemedicine, you can extend your reach. You can reach more than one individual at one time. You can reach caregivers. You can reach many patients at once. So I think that many-to-one concept is another way to improve the entire model of delivering care. So there's lots of creative ways, and we're just touching on them, which telemedicine can improve the current conduct of care. 24-hour access. There's hundreds of things. We're restricted right now to our clinic being open from 9 to 5, Monday to Friday. If I want to see a patient at 6 o'clock right now, I can't do it. Clinic isn't open. That's nonsense, right? That's when patients want to be seen. Saturday morning, I can't do it. If I want to see patients after I go to bed on the West Coast, or after my kids go to sleep, can't do it. Hundreds of different ways that it can be done and better.
I think the short answer is it certainly can expand access to care and improve productivity. I know in our specific situation, the ability of us to see patients via telemedicine in our office that we generally work in and not have to go somewhere else to see patients has a dramatic effect on our productivity.
Yes. So it would seem that this is a cost-effective way of doing things, and there should be some natural sponsors for this. It would seem the insurance companies should be a sponsor for this. The government should be a sponsor for it. Organizations of doctors should be a sponsor for it. Who are the existing sponsors of this? So
right now, our research is being sponsored by the nursing home. So the nursing home has a financial interest in, in filling beds. Retirement communities have an interest in, providing great care to their residents. They have an interest in, not having their patients have to go to the hospital. Two different insurers have expressed interest in this model with us. Excellus, the local Blue Cross Blue Shield insurer in our area, has committed to funds to provide virtual house calls to individuals. We just had a conversation last week with United Healthcare, who said that if I had a Colorado license, they'd have me doing telemedicine last week. So the payers are coming around to it. We're researchers, so we write grants. We write lots of grants. Foundations will probably be the next adopters, and I think there's increasing interest from federal government, Department of Agriculture, rural medicine to see this model expand. But again, it's just partnerships, creativity, and will that are necessary to make it done. Kevin and I can't do it by ourselves. We don't have all the capabilities and resources that are necessary to do it.
Problems dealing across state borders?
So currently in the United States, telemedicine is restricted by you have to be licensed in the state in which the patient resides. Used to be that's a major barrier. Now it's predominantly a cost barrier. There are third-party providers who can get licenses for you in all different states. So I'm currently licensed in New York and in California. You're licensed in New York and Pennsylvania, I think, and Maryland. So you can readily expand licensure. And then overseas, those are some other issues that we need to look into. But people are, coming in frequently to tertiary academic medical centers like Stanford, spending thousands of dollars in transportation costs to come see their physician, to get a bill for $300 and then to disappear and never be seen by that physician again. Now you can send them home with a webcam and say, we'll see you in 3 months. And we'll save you the thousands of dollars, and you can give us a little contribution of that.
That's great.